morning, everyone. Thank you for joining us for this quarter's waiver review presentation. This is Misty, and so this is our typical quarterly review for the waiver performance measures. However, because there have been several recommendations from both the waiver review committee when we met last time, as well as the supervisor meeting, there's been a lot of recommendations and feedback related to waiver. So we did condense the presentation to only include the level of care results, the service plan results, and then any performance measures that have related changes that have been discussed, like you said, at either the waiver review committee and or the supervisor meeting. We will be sending out a full presentation with all of the actual performance measures within, just to meet our CMS requirements and what we have indicated that we're doing in our application. But the presentation today, like I said, is a bit condensed. So I'll just quickly go through the level of care and service plan performance measures, which are the ones that are most relevant to you out in the field. And so you'll see here the level of care performance measures. These are assigned to supervisors to review by the 15th. They complete those reviews by the last day of the month typically, and the remediations for the level of cares are due by the 10th. So new applicants who had a level of care determination prior to receiving services this quarter was at 100%. Consumers who received an annual level of care determination within 12 months of their last level of care determination was at 98.08%. Consumers whose level of care determination included the required documentation was at 99.56%. Level of care determinations, initial and annual, made where the level of care criteria was accurately applied was at 100%. And this slide here just identifies, there's been a little bit of confusion primarily discussed at the supervisor meeting related to whether there's an initial or annual review and how to review it basically. And so this is really kind of more a change on the nurses side, but we just want to let you know there on the MRT communication form where it says, you'll see the blue arrow where it says reason for request. Whatever you mark there is how it'll be identified on the actual level of care determination form as well. So what was happening prior was the nurses, when completing these forms, would maybe put, for example, a changed level of care determination, or I can't remember if that's the actual title, but they would do that if a person, for example, was coming from the nursing home and then, going to an assisted living. So it was a level of care change on the nurses' side, but they were an initial.
Still working on it.
An initial determination for waiver. It caused some confusion when the supervisors were reviewing the cases. So again, if you are doing an initial determination for waiver, you'll mark the box initial determination, and then that will correspond with what is on the level of care determination form. So this shouldn't really be a change for you, but we did just want to point this out, that make sure that you're marking the correct box on this MRT communication form. Okay, so moving on to the service plan performance measures. The first is the consumer care plans that address all assessed needs. We just wanted to point out here, as you see, there's a pretty significant increase from quarter 1 to quarter 2 with this one, so great job there. We have made some ongoing updates to policy and the care plan document in an attempt to really bring this above the 86% threshold. And I think maybe for the first or maybe second time in the entire process of this performance measures, we are above the CMS threshold with this performance measure. So we just wanted to kind of express our appreciation and excitement there for that. So great job. Keep up the good work. And then consumer care plans that address health and safety risk factors, which is a subset of the previous one we just talked about, also saw a pretty nice increase there. Consumer care plans that address personal goals is at 92.63%. Consumer care plans that are developed in accordance with the state's policies and procedures. Again, this is just all the service plan performance measures compiled, so we're always a bit low here because it looks at everything within the care plans. However, you will note here that we did bring this up from last quarter, so we are showing improvement there as well. Consumer care plans updated or revised annually is at 95.71%. Consumer care plans updated or revised when consumers' needs changed is at 95.79%. Consumers who receive services in the type and scope specified in the care plan is at 100%. Consumers who receive services in the amount, duration, and frequency specified in the care plan is at 100%. Consumers offered choice between waiver services and waiver providers is at a 97.89%. And then moving on to the health and welfare. So this shows all of the health and welfare performance measures again. However, we will not be reviewing all of those. Like I mentioned earlier, we did condense some of these. So the first one is complaints regarding providers that were addressed within required time frames. And we're doing well there with a 93.33%. At this time, this includes the in-home provider complaints from SAMs as well as the AL waiver residents, which are in Ombuds Manager and reviewed by the Ombudsman. We did, however, make some changes to the complaint policy just because we realized that it hadn't been updated after the Ombudsman change last summer. So Leslie's going to talk more specifically about the changes that were made.
Yep. So as you can see on the slide there, what I tried to do is show the changes in the blue. So if you look on the left, the blue text was changed to what is in blue on the right side of the screen. So for individuals residing in assisted living or nursing facility, it used to be that we documented it according to the South Dakota Long-Term Care Ombudsman Program policy, but now specialists will refer those to the Long-Term Care Ombudsman Program by emailing a completed LTCO program referral to the ltco@state.sd.us email address. In addition, complaints received from non-ASA consumers, as you can see there, was changed to LTSS consumers, and instead of what it says on the left there, now we need to document a summary of the complaint, and we've added an ADRC outcome of complaint against provider. So if you can check that box when you're documenting a complaint from a non-LTSS provider, we can pull those reports into our complaint review process. And the only follow-up that you would need to do on a non-LTSS consumer is if there's abuse, neglect, and exploitation suspected, in which case you'd follow the Adult Protective Services policy. Just as a reminder, the purpose of the complaint policy is really to track and seek resolution for complaints, and that ensures that individuals' rights are protected and assists in preventing abuse, neglect, or exploitation. In addition, seeking resolution of the complaints in a timely manner provides an effective way to monitor and improve the provision of services. And largely what we're responsible for is to identify trends and patterns. And so we need to have a way to kind of track complaints per the provider. And so that's why we want all complaints about providers documented in a way that we can pull that data out and actually start tracking our providers. The policy is specific to complaints about providers, specifically providers of LTSS services, but for complaints about consumers from providers or other people, please use the other journal types. This complaint journal type is really specific to complaints that we receive about providers, not any other complaints. In addition, in the course of reviewing documentation for some other reasons, there were some complaints about providers that we found within documentation under other journal types. So maybe it was completed under a narrative or a phone call. So we just wanted to remind all of you that you really, please be sure that you're documenting the complaints about providers using those 3 journal types of complaint, complaint follow-up, and complaint resolution, as we are required to report these as part of our performance measure review. And the only way that we can pull them into the report that we have is that those journal types are used and that ADRC outcome is marked for a non-LTSS consumer. And just one other note about that, we don't think you're going to get a lot of complaints from non-LTSS consumers, but we still wanted you to have a way to document it if you did get a report. For critical incidents where appropriate follow-up occurred, we're at 73.68%. And there were some significant changes made to the critical incident policy based, like Misty said earlier, on the waiver review committee, the supervisor meeting, in addition to the policy work group. So first there, we did change both the complaint and the critical incident policy, with our transition to DHS. We added a table of contents to the critical incident policy to make specific sections easier to find.
So just a note there with the table of contents that you can actually just click on, in case people don't know, you can actually just click on the section within the table of contents, and that's where we think it would be much easier to navigate the policy. If you're looking for something specific, just click on it within the table of contents. It'll take you straight to that section within the policy.
Yep. We did update or modified the wording under purpose, and just wanted to remind everybody that the purpose of the critical incident reporting is to establish uniformity and consistency with documenting, evaluating, and tracking serious or severe occurrences, as well as identifying trends and patterns of critical incidents so that we can ensure the health, safety, and well-being of individuals and prevent future occurrences when possible. That next bullet down, we did update guidance regarding the critical incident unspecified reports received via the Health Information Exchange. We're going to review this a little more thoroughly because we also updated the HIE policy here in a couple slides, but basically reports do not have to be documented under the HIE and the critical incident unspecified journal types. And like I said, we'll review that a little more thoroughly here in a minute. In addition, we added 2 critical incident types, restraint and seclusion, to the policy, and we updated the form to include those types. On the next slide, in the handouts for today's presentation, we updated the flowcharts for death, missing person, and serious injury to make it a little easier to determine follow-up and documentation requirements. We did get a question about some of the follow-up on that, and the question was about how do we know if the provider notified DOH. So for anybody living in assisted living or nursing home for the death, missing person, and serious injury, the follow-up requirement is that you ask the provider if they reported the incident to the Department of Health. And the question that we received is, do we take the provider's word for it, or do we actually check with the Department of Health and make sure that they receive that report? Ideally, we would be doing this, but we did not want to add another requirement at this time. We are working on a process in which the critical incident review team would confirm with the Department of Health that incidents requiring assisted livings to notify DOH were in fact reported to DOH, but we haven't been able to figure out an easy way to do that yet. So we will keep determining how we can move forward with that. In addition, just on this screen, the definitions of restraint and seclusion are listed there. Restraint is a specific intervention or device that prevents an individual from moving freely or restricts normal access to the individual's own body. This includes chemical or medication restraints that restricts the freedom and or movement of the individual. Typically, if an individual can easily remove the restraint or the device, it does not qualify as a restraint. And then for the critical incident seclusion definition, this is involuntary confinement of an individual in a room or area from which the individual is physically prevented from leaving. The next two slides are just the report of critical incident restraint and seclusion flow charts. These were provided to you in today's materials, but I wanted to point out there that restraint and seclusion, the Department of Health has asked us to handle these a little bit differently. Restraint and seclusion are not allowed in assisted living per South Dakota rules. And so if you receive a report of restraint or seclusion or see it with your own eyes, they have asked us to report that directly to the Department of Health complaint coordinator. There you see on the left side. And the email address and the phone number is listed there. That we ourselves as LTSS staff need to report these directly to DOH. And then down below that, you may also want to make a referral regarding these situations to the Ombudsman program. On the right side, if the individual resides at home or registered residential, of course we would want to request a critical incident report form if the LTSS provider reported it, and document the restraint in the SAMS journal. Then you'd want to document the receipt of that report and scan it into File Director if it's applicable. You're going to want to follow up with the consumer to obtain more information about the restraint being reported or the seclusion that the consumer is experiencing. If the consumer's response does not give the specialist reasonable suspicion of abuse or neglect, the specialist may need to follow up with education to the consumer, the provider, the caregiver about restraints, and potentially provide some suggestions for other less restrictive solutions. If abuse or neglect of the individual is suspected, you'll want to follow the Adult Protective Services policy for further guidance. This is the report of critical incident seclusion flow chart, and it's pretty much the same as the restraint flow chart, but we still wanted to keep them separate as the flow charts. However, in SAMS, restraint and seclusion are combined as one journal type.
So, sorry, this is Misty, and I just want to jump in here real quick and make kind of a clarification. We should have spoken to up front a little bit, but we didn't. So, as I believe everyone is aware, with the reorganization from DSS to DHS and the Division of Long-Term Services and Supports, we were required to do a waiver amendment with that. And I believe we've spoken to the other changes that we kind of have talked about making. During that amendment process, we had several contacts with CMS, and they kind of went back to some of the things that were in our waiver renewal application. So once you do an amendment, it really opens up your waiver to a full review. And so CMS took that opportunity to kind of identify some other concerns that they had with our waiver. Specifically, one of the things that they brought up is that they really wanted to see us have restraint and seclusion as specific critical incidents. So prior, we had a performance measure, as you know, I believe. When we did the renewal, we did add a performance measure about restraint and seclusion as far as a survey question. So what CMS came back and said to us during this amendment was that that can't be our only measure of restraint and seclusion. So they recommended or requested us to add restraint and seclusion as specific critical incidents. So I think we kind of jumped the gun a little there and didn't explain all of that, but that's why you see here that we have restraint and seclusion as specific critical incident categories. We did receive approval on our amendment actually just on Monday. So we will be working on adding some other things sometime here in the near future. But because we were already updating the critical incident policy, we wanted to put these in here knowing that we would have to report out on them. So we don't anticipate that there will probably be a lot of these, but what CMS recommended we do is really compare any critical incident restraint and seclusion that we get as a critical incident report to the survey results to see how that compares. We identified when we spoke to CMS that we thought this would probably be very uncommon, and they just recommended that we do it this way anyway. So that's a little background on why we added restraint and seclusion as specific critical incident categories.
We do have a question in the Q&A. It says, what about cases of quarantine due to health? Would that be an exception? Karen, I assume what you mean is, would it be an exception to actually documenting the critical incident? I'd say we'd still need to document that somebody's being secluded for that reason.
We would still need to report it to the Department of Health per the policy here, and I think that would really be their decision to determine if that's appropriate or not.
Yep. In addition to those changes, we did update the critical incident policy due to the ombudsman changes that occurred back in July of 2017. So you'll see those changes in blue. Basically, on the top section there, you no longer have to submit a critical incident for individuals residing in assisted living or nursing home to the state long-term care ombudsman, Donna, in an email. So that's been removed as one of the requirements for follow-up. And then within the critical incident policy, under every single critical incident type, it talked about what you would need to do in the event a complaint related to the critical incident was also received. And so we just kind of combine those all together and put it at the end of the critical incident policy that if you do receive complaints about providers when you're receiving the critical incident report, that you would want to refer to the complaint policy for additional guidance. And as we just talked about, we updated the complaint policy to include what to do in each of those cases. Before moving on to the HIE policy updates, does anybody else have any questions so far on the presentation?
Yes, we do in Aberdeen.
Yes?
Can you hear me?
Yes, we
okay.
can hear you.
So if, as they're walking through an assisted living or a nursing facility and they would see someone who's restrained or they believe to be secluded and they're not a consumer of ours, how would we open that up as like a call then, or would it be no documentation required in SAMS as far as reporting that to the Department of Health?
Give me just a second. So under the critical incident policy, page 10, if we get a call regarding death, missing person, restraint, seclusion, or serious injury for a non-LTSS consumer, you do want to document it as a call in SAMS. If the incident is related to death or missing person, you want to advise the caller to report it to law enforcement if they've not already done so. And the only other requirement for LTSS staff is if there's any abuse or neglect or exploitation suspected, which in this case there certainly could be, and then you would need to follow the Adult Protective Services policy for follow-up. But as far as the critical incident report, you do need to document it as a call in SAMS, and then determine whether or not you need to follow up per APS policy. Does that answer your question, Tracy?
I don't think so. So we're talking about the restraint seclusion piece.
Oh.
So specifically, if they would, through the course of visiting someone at the nursing facility for a Section Q or being in assisted living for a review, and they would witness someone who's not an LTSS consumer, who they believe to be restrained or to be secluded, and then the requirement, if I'm reading that correct, is that then they would report that to Department of Health. How would that look for the documentation piece of it.
Right.
Yeah, so we didn't include that in the policy. But just kind of in discussion here, we think it would be appropriate that if it's in an assisted living, restraints are never allowed there, that it would be appropriate to to follow the same, make a complaint to DOH. So we will add that. In the nursing home, restraints may be appropriate at times, and so we'll further discuss how we want to handle that and add some information to the policy.
Thank you for pointing that out, Tracy.
Okay, thanks.
Any other questions? Okay, so on the health information exchange policy updates, we did change the wording under definition, purpose, point of care, exchange, and notified, just to improve the readability, kind of make it less formal, per the policy work group's feedback. We also added guidance regarding consumers who have closed for waiver but were not removed from the waiver consumer list and notify. So what we were getting is, it sounded like maybe consumers were not being removed from that list and notified quickly enough, and they were still getting notifications. So here's some guidance for what to do if that happens. Obviously, when a consumer no longer qualifies, you want to remove that consumer from the list as soon as possible, or you will continue to receive notifications for the individual. However, if they are no longer on waiver, the HIE documentation requirements are not required. If the consumer is receiving services through other LTSS programs, you do need to refer to the critical incident policy for follow-up and documentation guidance of the critical incident. If they are no longer an LTSS consumer, the notification can just be regarded altogether. We do have another question in the Q&A. It says the APS manual hasn't been updated since 2014. Will that be done soon to reflect our changes? Yes, I know Cassie's been working on that. It's currently being done, and I assume that will probably be coming out shortly in the next month or so, maybe. Cassie's been on maternity leave, so I'm not really sure where she is in that process, but I do know that she's been working on making updates. So for the next HIE policy update, the policy used to say that all HIE admit notifications must have one HIE admit, at least one follow-up, and one of the 3 HIE resolution journals. That has been changed to what you see there on the right. Multiple notifications for the same event or hospitalization can be documented together. Each event or hospitalization must have one of the 3 HIE resolution journal types. So we need to see documentation of successful diversion, long-term care, or neutral once your follow-up has been completed. And just a note on that, that HIE resolution journal note is the most critical as we're using that data, the data from these outcomes to assist with our LTSS initiatives, specifically with our diversion efforts and our goal to increase the use of home and community-based services. The HIE admit and the HIE follow-up journal types are there for your use when needed, but are no longer required for all notifications. However, for example, if the consumer is in the hospital for several days, you do have a way then to track follow-up before resolution is determined, because it could mean that you want to continue to track any follow-up that you're having regarding that hospitalization, and you won't know the outcome right away. So you might want to use those journal types just to kind of keep track of where how the situation is, rather than waiting until the end to document everything in that resolution journal. So they're still there for your use, but they're no longer required for every single notification received. So on the HIE resolution types, we did make some changes here as well. At the top there, really every single time contact is made with the consumer's family, the discharge planner, hospital staff, the question, has facility placement been discussed or considered, should be asked in the response document in the SAMS journal. The answer to that question is going to be actually what helps us determine which of the HIE resolutions should be used. And we created a flow chart, which we're going to go over in the next screen, but we also did update the HIE resolution successful diversion wording just slightly to make the guidance a little more clear regarding when to choose that resolution. So there you can see that you're going to choose the resolution if the discharge plan or discharge planner indicated at any time during initial or follow-up communications that the consumer would be admitted to a nursing facility at discharge. However, due to specific LTSS staff intervention, the consumer was not admitted to the nursing facility after the hospitalization and returned either home or to an assisted living. So in other words, without LTSS staff involvement, the person would have likely been admitted to a nursing facility. That's the only time you should use that HIE resolution. On the next screen, though, is kind of a flow chart that we developed to help determining which of the resolution journal types you should use. So when you're documenting that outcome, you really need to determine, was nursing facility placement ever discussed or considered during that hospitalization? So if the answer to that question is no, it automatically is an HIE resolution neutral journal. In addition, if the consumer was not admitted to the hospital after an ER visit, or if death occurred prior to the consumer's discharge, those are the reasons that you'd use HIE resolution neutral. If the answer to that question is yes, then the next question is, did LTSS staff have the opportunity to provide options planning or discuss with the consumer, the family, the discharge planner, hospital staff, how LTSS staff could assist, or LTSS services could assist the consumer to discharge home or to an assisted living with needed services instead of being admitted to a nursing facility? So if you as the specialist never had an opportunity to do that, the answer to that question is no. Then you ask, was the consumer admitted to a nursing facility at discharge? If it's a yes, it's a long-term care admission as HIE resolution. If it's a no, it's an HIE resolution neutral. If the answer to that question about LTSS staff involvement was yes, then you need to ask yourself again, was the person admitted to a nursing facility at discharge? If it's a yes, it's a long-term care admission. If it's a no, HIE resolution successful diversion is what you would select. This flowchart was also sent as a separate document in today's webinar materials. Are there any questions about the flowchart before we move to the next screen?
This is Beth. I just want to jump in and reiterate one point that Leslie already made. But anytime that you're making contact with either the consumer or more likely the discharge planning staff at the hospital, it's really a good idea, and we want you guys to be asking that specific question: has nursing facility placement been discussed throughout the discharge planning process? And then we want you to document that, or make note of that as part of your documentation. That's really going to help, like Leslie said, drive what the resolution or outcome is for that particular individual or that circumstance. So please, when you're making follow-up contact regarding the HIE notifications, always ask that question to the discharge planning staff: has there been discussion of nursing facility placement?
And like I said earlier, this information, we are tracking this as part of the LTSS efforts. And so as we go through the monthly reports and kind of looking at what the outcomes were, that's largely going to drive, our next steps in how we can prevent nursing facility placement when we can provide services in the home instead. So it's just really important that we have those outcomes documented so we can kind of figure out what we do next if it's not, if the outcomes aren't improving, let's say, with the successful diversions. The other change to the HIE policy is regarding critical incidents. There on the left is what it used to say. On the right side, we did update it to indicate that actually all HIE notifications are critical incidents. And so there was no change, in that second bullet. If you're getting a critical incident notice that includes death, missing person, restraint, or seclusion, a critical incident journal note must also be documented in addition to the HIE documentation requirements. However, if a critical incident unspecified report, so hospitalizations, ER visits due to illness, stroke, heart attack, malnutrition, dehydration, all the critical incidents that don't fall under one of those 5, you only need to document the critical incident HIE notification using the HIE journal types. It is not necessary to also document the report as a critical incident unspecified. If the report is not received via the HIE, the report must be documented using the critical incident unspecified journal types. So in other words, critical incident unspecified reports do not need to be documented under both journal types, but must be documented under one or the other. And how you determine that is where you receive the notification.
This is Beth again, and I do just want to recognize we have had a few successful diversion situations or scenarios brought to our attention recently, and I really appreciate those. So if you are involved in a situation where we are able to successfully divert an individual from a nursing home placement, please share those with us so that we can kind of take those back during our steering committee meetings with leadership. They are very interested to hear those stories of how the HIE has been successful. So I appreciate all the work you guys are doing in this area, and please share those as you have those successful situations come up.
Okay. Before moving to the next section, did anybody have any questions about the HIE policy updates?
This is Beth again. I'm just going to jump in one more time, and I just want everybody to recognize or understand that we recognized with some conversation through the waiver review committee and the supervisors that this process is very cumbersome. You're getting lots of notifications, a lot of times on the same individual, having many different steps within the process. So first they're admitted to the ER, then they're discharged from the ER, they're admitted to the hospital. Maybe they're transferred within the hospital. So we understand that it's kind of a cumbersome process. Again, want to point out you're really not required, or you really shouldn't even be looking in the point of care exchange for any relevant or recent information on the hospitalization. It's likely not going to be there until the patient is discharged. And so again, it's really the purpose of the HIE is to just make it known that the individual is in the hospital or accessing the ER. And then how can we potentially be helpful in diverting those nursing home placements? So just again, want to point that out. I know we've said that in the past, but want to reiterate that, if you're looking for information in that point of care exchange prior to contacting the hospital discharge staff, it's really not a good use of time. It's not going to be there until likely after the person is discharged. So again, just the most important piece of this is really making contact to the consumer, the family, the hospital staff to be involved in the discharge planning process.
Mm-hmm.
So hopefully with, kind of removing some of the requirements to make all those journal notes and the admission and the follow-ups, we're hoping that will reduce some of the burden that this process is kind of putting on your workload.
Mm-hmm. I would also add that anytime you're dealing with a complaint, a critical incident, or an HIE notification that you're not quite certain how to follow up or what kind of documentation you need, what steps you need to go through, please contact us. Sometimes those situations can be really unique and different than what you've handled before, and so anytime you need any assistance, please let us know. Next slide. This is the consumers who were not restrained or secluded while receiving services. This is the performance on the last quarter's quality of life survey results. We had updated this during the last review period, and then, like Misty stated earlier, CMS asked us to, in addition to this quality of life survey question, ask us to also add restraint and seclusion as specific critical incident types. And so this quality of life survey question is still included on the quality of life survey, and we still want it to be asked. The one change we made with it is when you hover over the question within the SAMS quality of life survey, you will see that message there that says if the response is anything other than never, you need to ask more information about the restraint seclusion, document the consumer's response in the quality of life survey note, and follow up per the critical incident policy. Because restraints and seclusion have both been added as critical incident types, the follow-up guidance and documentation requirements are all included in the critical incident policy. If the consumer resides in assisted living, you want to immediately notify the DOH complaint coordinator, and that was per DOH request. The other note we wanted to make here is we did get a request to change this question. We realized that it does seem a little backwards compared to the other questions in the survey. But in looking into that, we realized that that would create problems with the data collected up to this point. It would actually change all of the prior data to the exact opposite of what it is. However, we will continue to monitor this and discuss it more as we move forward.
Before we move on, were there any questions regarding the last couple of slides in that question within the quality of life survey?
All right, going back a bit regarding the complaint policy. If a consumer expresses a complaint with a provider but does not want their specific complaint addressed with the provider, do specialists simply document the complaint with no follow-up or resolution? Or specialists go against the consumer's wishes and address the complaint with the consumer?
In a situation like that, it's important still to go ahead and document per policy and just indicate, that follow-up was not completed with the provider. Maybe there's some other follow-up that could potentially be completed in order to somehow resolve that issue. It's still important to go through the steps. So continue to follow policy and, obviously document that they didn't want you to follow up with the provider.
Okay. If such a situation occurred and there were concerns of abuse, neglect, or exploitation, though, we would still need to follow up per APS policy.
Okay, and if you have any other questions, continue to feel free to use the question and answer box as we move forward with the presentation here. The next area is financial accountability, and as you'll see, there's a couple in red. Those are the two newer performance measures that were added with the October 1st, 2016 waiver renewal. We've reviewed them a couple times, but we're really still kind of figuring out exactly what we need to do in those areas. So the first one here is and we're really just reviewing those second two. So the number and percent of survey respondents who reported they received the services that are authorized. So just a little background on how we will be determining compliance with this performance measure. And again, as we kind of started this review process, we identified that we needed to provide additional guidance and really explore this a little bit further. So first we'll be identifying a random sample, which we'll take all the surveys that were completed and then pull out a random sample. If the answer in that random sample to this question is always, then those are going to be considered compliant right off the bat. If there's responses other than always, The state office staff will request documentation from providers and compare the documentation to what has been billed for the consumer. So really the point of this is to make sure that whatever the provider has billed for were actually services provided to a consumer. So if the billing, okay, so we will request documentation from the providers for anything that's an answer other than always. And then once we review that documentation, we'll determine if it matches what was billed. So obviously the documentation and the billing needs to be the same number of units, the same type of services, those types of things. If it does match, then that case will be considered compliant. However, if it does not match, so the documentation does not match the billing. So for example, the billing or the documentation shows that the service wasn't provided because the consumer wasn't home. But then maybe they billed that service anyway. That wouldn't match, and that would be considered non-compliant. If it's non-compliant, then the corrective action will be taken, and this may include or will include the provider paying back money for services that weren't provided. It may include a referral to the SIRS unit to complete a more thorough review of the provider. So if we identify this and maybe do a little further digging and identify that this is a broader issue, we would refer that on to the SIRS unit. The SIRS unit is the surveillance unit who looks into fraudulent type claims. So basically, in reviewing the sample that we had pulled for this quarter, we really identified that we hadn't provided enough guidance in our original policy. What we ran into is we had several survey responses where the consumer answered something other than always, so maybe sometimes never or some of the other options. But those answers, upon further follow-up with the specialist, weren't really related to the LTSS services. So what we did was we made an update to the SAM's quality of life survey just to help staff, remind staff to the follow-up requirements. So what you'll see when you come upon this question within the survey is if you hover over it, you'll have this little reminder that you need to ensure the answer is specific to services being provided through LTSS. If not, please direct the consumer to comment relative to LTSS services. If the answer is not always, the specialist must note specific services not received and the reason if known. So any response that is aside from always, so any of the other responses really needs additional documentation about the service not being received. And again, the reason for this is that we're going to be requesting documentation from the providers. Some of these individuals have, as you well know, 5 or 6 providers, and so we need to know which documentation to request. More often than not, it's probably going to be the in-home providers. But to avoid just requesting a bunch of information from providers, we really need you to dig down and understand why they're answering that question, what specific services they're talking about. Like I mentioned, each response other than always will require a billing review for that month, as well as a documentation review. So it's going to be extremely important and helpful to know more detailed information regarding the services not received and why they answered it that way. Like I mentioned, if the consumer is authorized to receive more than one service, the specialist will really need to ask additional questions to determine which service the consumer is referring to and document that information within the survey notes or the SAM's journal so we can appropriately follow up. If a consumer resides in assisted living, so we ran into this a couple times too, where someone resided in an assisted living, they answered something such as sometimes to this question. Really, again, with this, we'll need to find out, are you referring to the assisted living service, or are you referring to medical supplies or nutritional supplements or something else that the consumer is providing within the assisted living? Because if the consumer resides in an assisted living, that actually is the service. So as long as they stayed overnight every day that previous month, they receive that service. Now, if they're not receiving the number of baths they want or something like that, then that could potentially be a complaint and followed up through the complaint policy. But if they're actually receiving the assisted living service and were there that entire time, this answer would be always. we're not going to be able to identify through a documentation request from the assisted living if it's, I didn't receive 5 baths or I didn't, those types of things. So again, with this for ALs, if unless the consumer actually did not stay overnight at the AL on specific days during the month, this is going to be always. All other issues related to the AL service would need to be documented through a complaint or other means.
And just a note, that message there where it says ensure answer is specific to services being received on the screen will be the wording that pops up when you hover over that question in the quality of life survey. We do have a couple questions in the Q&A. So they want to know who will be pulling the documentation for these cases and asking the providers for their documentation.
So at this time for this round, I requested the documentation from the providers. Again, we've kind of just been trying to figure this one out as this is the first quarter that we've done it, and so at this time I did pull that. I have been in the process of reviewing the documentation but haven't completed it at this point, which is why the performance measure wasn't fully complete. But so we'll be working on that, and then I think there were probably 4 to 5 in this current survey sample that indicated something other than always.
The second question is, are these going to be pulled solely from the quality of life surveys, or should specialists be emailing their supervisors when they have cases like this?
For now, we're just going to pull them from the surveys. We are kind of tossing around the idea, do we need to be looking at all the no answers in addition to a random sample, or just looking at the no answer, or I'm sorry, other than always answers. We're still kind of tossing around how exactly we should be handling this, if we really need to be looking at anything that says no. We will potentially be, looking at that just because we think that if someone's not receiving their services, it might be important to look at. But part of what will drive our further steps in this will really be how accurate we find that those survey results are. So again, if we're seeing a lot of other than always, but we find out that they're really not receiving the service, then that'll kind of determine our next steps with this.
Any other questions on that before we move forward?
I guess I should mention quick with that one too. Obviously, if you have a situation where you think a provider is fraudulently billing, we've had a few of these where for whatever reason that's come up where the consumer, has reported they're not receiving the service or there's some kind of conflict. I guess you should always bring those to our attention. And like I said, if it's considered kind of a widespread issue with an agency, it's likely we'll refer that on to the CERS unit. Just a reminder, we should not be making direct referrals to Mafuku or Paul Kramer's group. Those should always come to the program managers of the state office and will then be filtered on to the CERS unit. Okay, so moving on just to some other reminders and other updates that we wanted to point out here. So the first is the DME, or Durable Medical Equipment Protocol. We've had a lot of questions, concerns from providers regarding this process over the past few months since it's been in place. Just a couple things. So we wanted to just kind of discuss this and make sure that we're kind of following the actual protocol. So first thing I just want to note, it is the updated protocol. It was updated a few weeks ago because we identified the length was not correct and there was some more language we wanted to include within this protocol. So it is available on the internet, the most updated version. It has been moved though to long-term services and supports policies and then durable medical equipment protocol. It was previously, I think, under forms, it was difficult to find there because it's really not a form. So move to policies. Hopefully it'll be more easily accessible now. So the updates made to the protocol recently were, like I said, we updated the link within that document because the previous one was not working because it was a old fee schedule. So what we ended up doing is we we put the link to the actual Medicaid site versus the actual document itself so that it hopefully does not become broken again as they update that each year. We don't want to have to update the protocol each year. So there's directions on the protocol as to how to get there, and then you'll have to go down to the other fee schedule. So refer to that document for that. So the other thing that we included here is if you're unable to locate a HCPC code on the DME fee schedule. So you look at the list, it's not included in there. You'll want to look to the DME fee schedule. If it's not within that document, you should forward to the HCBS waiver manager the HCPC code that the provider has reported they're going to use to determine if that item is covered. So basically, all items are not in the fee schedule. So that's the reason for that. So just wanted to point that out. But we're going to actually go through step by step again just to make sure that everyone is following this. Because what I have identified through conversations with providers who don't like this process, at least a few of the providers have noted that the specialist is not asking them for the HCPC code that will be utilized. The only time providers should be required to bill Medicaid is when we actually know that the piece of equipment is covered by Medicaid, either because it's on the list, on the protocol, or because the specialist has obtained the HCPC code and has either found it on the fee schedule, or they've emailed the HCPC code to myself, and I have identified that it is not in the system. So really, the only time we should be asking providers to submit this to Medicaid is when we know Medicaid will cover it. So just want to clear that up. So the first step is that the LTSS specialist will assess the need for the medical equipment supply and determine if it is covered or not covered. This is directly taken out of the policy, so there's not a chart above, but refer to your DME protocol. If the item requested is not indicated on the chart, contact the DME provider and ask for the HCPC code. Once the HCPC code is received, you need to search the DME schedule located on the DSS provider fee schedule. And this is where it says, scroll down to section titled Other Services to see if that HCPC code is within the fee schedule. If it's not on the fee schedule, you will need to forward that HCPC code to me, like I said, to determine, and I will determine if it's within the MMIS system. It's a fairly quick process, so I should be able to get back to you fairly quickly. If it's covered, you'll proceed to step 2. If not, you'll skip to step 4, which is basically to authorize the services without the provider needing to submit that claim to Medicaid. Okay. So going on to DME protocol step 2, which is if something is covered by Medicaid. So for any new equipment supplies request, the LTSS specialist will refer the consumer to the physician for a face-to-face visit. So you're going to say something to the effect of, this is covered under Medicaid. Medicaid requires a face-to-face visit, so you'll need to visit your physician to get a referral for this. For any ongoing routine equipment supplies or requests, so someone, for example, who's been receiving incontinence supplies ongoingly. So you're doing your annual review and they need them again. The LTSS specialist will refer the consumer to the DME protocol, or I'm sorry, the DME provider. The DME provider will likely already have the necessary documentation to submit the Medicaid claim without a need for the face-to-face visit. So the only time the face-to-face visit is required is for the initial approval of a piece of equipment or supplies. The physician will then complete a certificate of medical necessity, which DME provider obtains from the consumer or the physician, I'm not sure which. The DME provider will then submit the claim to Medicaid.
We have a question. If the HCPC code is on the schedule, does that mean it is covered?
Yes.
And we cannot purchase?
Correct.
I have talked myself around this procedure to believe both ways. Yeah.
Yeah, so if it's on the fee schedule, that means it's a Medicaid covered service. Let's see. And we can, yeah, and it shouldn't be authorized through waiver. Now, one of the complaints we've received, and it's a valid complaint, but it's totally against our waiver policy to do it anywhere else. It's against CMS regulations. Some providers are likely going to pull out of services because, for example, previously an individual, let's say, needed a very large piece of equipment that was maybe a $5,000 piece of equipment. And what we have done in the past is, if we think the person needs that, we authorize it at the usual and customary fee of $5,000. However, so let's say that a piece of equipment is available through Medicaid. Medicaid will only pay, say, $2,600 for that piece of equipment. And so that's one of the reasons people or providers are not wanting to go through Medicaid, is because historically we have reimbursed more under waiver. One important thing to note, and we haven't really indicated this as much in policy, we haven't really made it a focus area, but we will probably upcoming, is when a piece of, probably more a supply, so let's say a pair of gloves, for example, is covered under Medicaid, but maybe there's a limit. But Medicaid, let's just say, pays $1 for the pair of gloves. Then waiver can only pay $1 for that pair of gloves. We can't then bill the usual or authorize the usual and customary fee. Like I said, we haven't really focused on that part of this yet. If you have any questions regarding that, let me know. But yeah, are there other questions? Like I said, the reason we wanted to point this out, we are having some issues with providers, as you're probably all aware. It's likely that we'll need to reconvene kind of with Medicaid and really figure out some additional resolutions if possible. But the one thing I wanted to make sure that we're doing is only requesting them to submit it to Medicaid if we know it's not covered, or I'm sorry, we know it is covered by Medicaid. If we know it's not covered by Medicaid because it's not on the list, it's not on the chart, and it's not in the HCPC file, we can just cover it under waiver.
Another question in the Q&A says, if the HCPC codes are covered under Medicaid, will they be covered under Medicare?
Not necessarily, I don't think. If they're not covered by Medicaid, we're at this point in time not going to require Medicare denial. It's very unlikely that Medicare would cover something that Medicaid would not.
Any other questions? About the DME protocol before we move to authorizations?
Okay, moving on then to authorizations. Obviously, like I said before, if you still have questions, stick them in the Q&A and we'll get to them. So with the authorizations, we just wanted to kind of do another reminder that at this point, all authorizations should be updated to transition the 04600s and 04650s to the S5130, T1019, and or T1000. Providers are no longer able to bill the 04600 and 04650. If they submit those claims to the SSIS, they will deny. We're not doing payments to those anymore. So just making sure that you have provided updated authorizations to all your providers. We should no longer be authorizing 04600 or 04650 service codes. They need to go on the Medicaid authorization form now, and they need to be these other 3 service codes identified here. Okay, couple other reminders regarding the authorizations. ICD-10 diagnosis codes must be included on the authorization. For the most part, I think we are doing this, but I just want to remind people because providers are still getting denials for this. If it happens that we've provided an ICD-10 code that comes back as a medical denial to one of our providers that is an invalid code, you can refer those to me and I will send them a code they could potentially use. The other thing is that the physician's name and NPI must also be included on all Medicaid authorizations. Again, the ICD-10 and the physician's name and NPI are only for Medicaid claims. So they're only for the Medicaid authorization. So recently, like over the last couple of weeks, our in-home providers have been having a lot of issues with this. Previously, this was required, but the edit wasn't put into place with Medicaid yet to have those be denied for this reason. It now is being denied for this reason. So you need to make for certain that the physician's name is on the claim, or I'm sorry, on the authorization form, and that the MPI also for the physician is on the authorization form. So just some reminders there. If we get some feedback from providers that they have an authorization that does not have these things, you will be asked to complete them again. Sometimes what you'll find is that you look at the authorization in File Director and it has those things on it. We would just ask them that you refax the authorization to the provider. So I guess don't be offended if you get those emails from us. We're just passing them on. So if that information is on there, it's simply I'm assuming the provider does not have the most recent one on their files for some reason. Okay, a couple other things regarding eligibility for waiver. I believe this has been pretty clear over time, but we do run across sometimes still situations where an individual appears to us that they would qualify for waiver. However, they have not been put on waiver or assessed for waiver. So just as a reminder, individuals that meet the criteria for waiver must be assessed for waiver. So if an individual needs personal care or daily nursing, or you have an indication that they're receiving some sort of weekly therapy, you need to assess those individuals for waiver. There was a little bit of confusion, I think, with some language in the manual after the renewal regarding the extension of the state plan. Nothing's changed, though, with this policy. All that language means is that we need to access our state plan services prior to waiver, and that's going to be automated with the systems with the MMIS claims. So again, individuals that meet criteria for waiver, as far as you can tell, do need to be assessed for waiver. However, individuals that are determined self-care are not required to complete a long-term care application prior to authorizing LTSS regular in-home services. So if an individual does meet the level of care for waiver, they need to complete the long-term care application process. And the reason for that is because we don't think that we should be using state funds for someone who could be utilizing federal funds. However, we've had a couple situations reported by EA, and I don't know if this is, a reoccurring issue or not, but I just had told them that I would pass on the information that, again, if you have a self-care determination, in that situation, we know they're not going to be eligible for waiver, so you don't have to require them to apply for Medicaid through the long-term care application process. Any questions on either of those two things? Okay, I am going to pass on to Leslie then for the rest of the handouts and reminders.
Yeah, just a couple more things here. We didn't really bring it up or review it on the webinar today, but within your webinar materials, you did receive an updated list of SAM's journal topics. Through the waiver review committee and the supervisor meeting, it was decided that we needed to kind of combine some and reduce the number of SAM's journal topics that you have to choose from, just to make choosing your journal topic and documenting a little bit easier. And so you have that in your handouts today. You also received updated copies of the Notify and Point of Care user manuals, and both of them have been updated to include a table of contents to make things easier to find within them. And you also received an updated Health Information Exchange, or HIE, acronym list. Those are all the acronyms for all the hospitals that are participating in the HIE. So if you see that acronym in the notification, you can use your acronym list to determine which hospital the consumer is at, to make finding them and following up a little bit easier. And then we just had a request to kind of remind everybody that when you are needing to complete an exceptions form to go above the maximum amounts allowed, you need to make sure that your CHA in SAMS matches the information that you're including on your exceptions form. So if, for example, the consumer had a significant change and the most recent CHA is no longer current, you must copy the CHA, and you click the copy button there on the screen. You can see in the image that you would click that copy button. And then after that, another pop-up comes up where it will allow you to change the date to the current date. And then once you save it, you can make your changes to the specific CHA sections that need to be updated to reflect the current status of the consumer. And then once you've updated the CHA with the current date, you want to make sure that your exceptions form reflects that same information. Basically, when those exceptions forms are being reviewed, we're going in to look to see if the CHA is matching the information on the exceptions form. So you don't have to completely redo the CHA, but you do need to copy it and change the date so that the most current information regarding that consumer is reflected in both places.
And just kind of a note here too, that one of the again, we're not going to get into the weeds on this, but we were required to add some additional performance measures with our transfer over to DHS related to administrative authority. And one is relative to the exceptions form, and that we approve them all according to our exceptions policy. So again, you need to make sure the form isn't basically going to get approved if you don't have matching information. So please just double check that when submitting those.
And I would also add that we don't want to make changes to the CHA that was done prior, because we do want to keep kind of a history of that information within SAMS. So the best practice and what we would prefer you do is actually copy it and make just the changes that you need to reflect that change for the consumer. Another comment just in general is that all of these handouts from today's presentation will be updated or added to the DHS intranet soon, along with today's webinar recording. And Jennifer Gant will be updating the SAMS information that we talked about on today's call very soon, either today or tomorrow. I would guess you'll see those changes reflected in SAMS itself. Before we review this last slide, does anybody have any questions regarding anything we talked about so far? I would also add that, as you look through the updated policies and forms and flow sheets or flow charts that we sent out, I would appreciate any feedback you have or any other suggestions to make all of that information a little easier to understand. Okay, so a question. To clarify the requirement to assess everyone for waiver, if through the South Dakota Choices screening process or at a review for an existing consumer on regular in-home services, an individual indicates they have more than $40,000 in assets, but they require help, for example, with personal cares, do we still require them to complete a long-term care application and pursue waiver eligibility?
So I would say with that, yes, with the resources. The reason being that there's a lot of resources that can be not countable on EA side, and so we don't really want to make those determinations. We want them to follow their rules and really identify if the person really is eligible or not. Again, there's so many benefits for an individual to be on waiver. They can have access to a larger care plan, a larger array of services. In addition, they get that Medicaid benefit. And so it's really in the consumer's best interest in the most situations for them to actually apply and determine if they actually are eligible. So I would say if they report those resources, we do want them to apply through long-term care just to ensure that they're actually all countable resources.
Okay, I don't see any other questions coming up in the Q&A, so I'm just going to review this last slide. But as we've stated, be sure to send us your questions or feedback after the webinar today if you have any thoughts or suggestions to share with us. This final slide is mostly just a request that we have for you. We are currently working on updating the assisted living request for modifications to the ASA care plan, which is page 5 in the care plan document, with some wording changes on the questions just to make completing the form a little bit easier. As you know, the questions that are currently on there, are long and complicated and somewhat duplicative. And so we're working on just making some updates to that, but before we actually release that updated care plan, specifically this page, we wanted to get some of your feedback. So on the right there, you'll see that we have some proposed changes. And I would just appreciate any of you that are willing to review that and give us some feedback about what we're proposing to change, if you have any thoughts or comments or suggestions for wording on those or additions. So it's just a request from us to you guys to provide some feedback on this specific document for us to proceed, and then hopefully we'll be able to release that soon. Another question in the Q&A, the issue of recoveries comes up from consumers applying for LTC benefits. It might be helpful to have this department speak on a future webinar. Okay, thanks for that suggestion, Pam. And if any of you do have suggestions on the AL request for modifications form, please send those thoughts and suggestions to me, and I will continue to work on making some changes to that.
So we'll stay on for a couple of minutes here just in case anyone wants to ask any questions. But just wanted to thank everyone for participating today. We do know that there was a lot of information and it was maybe a little longer than sometimes. So we appreciate your attention, and
I would also add that the performance measures for this quarter were really good. And just once again, thank you for all of your hard work. We appreciate all of the work that you do, and hope to continue seeing those awesome results.
So we did have another question in the Q&A. It is, if a consumer does not want to apply for waivers/Medicaid, do we get them the app and leave it at that? I do think we need to encourage people to apply for Medicaid, because if we, if they meet the level of care, especially if they meet the level of care for waiver, we cannot provide services to them through our regular in-home services program. Just because, like I mentioned, it's more cost effective for them to be on waiver, because the federal government picks up 50% or more of the cost of those services. So per policy, we would not provide our regular in-home program services to them. So, it's really up to you on how you handle that, but I would say that we should encourage them to apply. There is, way back, I'm not even sure where it is, but there's kind of a flow chart from a few years ago. I don't know where it is. Hopefully we'll make sure it was included in a webinar once upon a time, but it really kind of goes through the flow of the process that you could utilize regarding the Medicaid application, and that you need to send a notification, notice of action to them if they don't apply for Medicaid and they're eligible on the level of care side.
Another question in the Q&A. What we often see is that consumers qualify based on care needs but are over financial due to stated assets, i.e. needs for regular but not for waiver.
Yeah, that's fine, but we just need to confirm that they don't meet the financial criteria by economic assistance.
The next one, to clarify your last statement, if they don't qualify for waiver financially because they have $5,000 in assets, but they meet level of care requirements, would we deny them services under regular in-home care?
No, just if they meet the level of care for waiver, but they refuse to file a Medicaid application. If they filed a Medicaid application and we've confirmed they're not eligible, then of course we would provide in-home services.
Okay. Next one, if a consumer is receiving temporary skilled therapy, are we expected to assess them for waiver if they will not be needing personal care once therapy has been discontinued?
I would say if it's, it's just going to be temporary, I don't think that's necessary, but if it's going to be something that's ongoing or they would benefit from the Medicaid, then I would recommend still following the process. Okay, so like I mentioned, we will probably hang on here just until about 11:30 if we don't have any further questions, just to make sure that everyone has the opportunity to kind of ask questions. If there's no more, then we hope that everyone has a great day and great rest of the week. And like I said before, thanks for participating. We appreciate your attention for quite a long time here.